The study that we're talking about is the so-called ELARA trial. It's a trial of tisagenlecleucel, which is a CD19-directed CAR T-cell therapy, which has been previously approved for diffuse large B-cell lymphoma and for pediatric and young adult ALL in patients with relapsed or refractory follicular lymphoma. So these are patients that are beyond our current standards of adequate care. And so this trial was a multi-center phase 2 trial of this CAR T-cell approach. It's based on a pilot trial that we ran at the University of Pennsylvania that began in about 2014, and for which we treated 14 patients and have about 5 years of follow-up. So it's much the same design. It's gratifying that the overall response rates, and at least at this preliminary look that we had, match very much our pilot study that was done at Penn. I think the complete response rate was about 2/3, 66%, with a partial response rate of about 20%. That's pretty close to what we had in the Penn pilot trial. And at 11 months of median follow-up, which is what we presented in earlier this month, the median durations of response had not been reached for those that had partial or complete responses. The probability for any responding patient to remain in response for more than 6 months was 79%, very close to what we had in our pilot trial. And interestingly, this probably relates to the timing of imaging on this study versus the pilot trial. But of 31 partially responding patients, 12 of them converted to complete responses, generally between months 3 and 6. In our trial, we didn't do the first imaging unless it was clinically indicated until month 3, so we didn't see that early conversion of partial to complete response. I'm optimistic that this trial will continue to show that these responses are durable, because in the pilot trial that we ran, 60% of the patients were still in complete response after a single treatment with this agent at 5 years. So I think that this is exciting. It will complement the existing CAR T-cell therapy that's already approved. That's the Yescarta or Axi-cell product in follicular lymphoma, and it'll offer another treatment approach. The toxicity is very, very acceptable with this agent. There were no cases of grade 3 or higher cytokine release syndrome, and only one neurologic adverse event that was grade 3 that resolved. So it's very, very well tolerated. In general, I treat these patients as outpatients. So once a patient's identified as a candidate for this approach to therapy, and this will generally be a patient that has had CD20-based monoclonal antibody therapy as well as chemotherapy. And again, the patients in this trial had to have failed at least 2 prior lines of therapy, and these would be the types of patients that would need something else that could achieve this type of response and the durability that we see with CAR T. So once you've identified that kind of patient, the process is to collect the peripheral blood lymphocytes. This is done by leukapheresis. You hook a patient up to a machine, take the blood out, give the blood back, with the exception of the white cells, which conclude the lymphocytes. They can be frozen down and then shipped to the manufacturing facility where they are thawed and cultured and transfected with the a gene for the chimeric receptor that becomes expressed on the surface. Once the product has expanded and we have an adequate number of cells for dosing, which is in the order of magnitudes 10 to the 8th cells, between 0.6 and 6 times 10 to the 8th cells total CAR T-cell viable cells, it gets frozen and then shipped back to us. And then, of course, we give some lymphodepleting chemotherapy followed by these cells. So the process takes about 3 to 4 weeks from apheresis to when you get the cells back. So occasionally these patients require some additional therapy to try to keep them fit or stable medically to receive the CAR T cells. If their disease is rapidly progressing, this may be the case. Other patients that are reasonably stable, you can wait until you get the cells back prior to commencing with lymphodepletion and CAR T cell therapy. So I think that it's ideally suited for this group of patients because in the aggressive lymphomas where this is approved, it's much harder to keep a patient stable during that 3 to 4 weeks of manufacturing time. It's a little easier with the follicular lymphoma patients. So I think it's a product that will be utilized because of its tolerability and its efficacy, the ability that is of a single treatment to achieve a durable response. And I think it'll be a powerful agent in our armamentarium for treatment of those cases of follicular lymphoma that actually need something more than our CD20-based monoclonal antibody chemotherapy combinations. Yeah, like I said, the toxicity was very minimal. There were no cases of grade 3 or higher cytokine release syndrome using the Lee scale, and I think, but there was some usage of tocilizumab. I think it was about a third of patients did receive some anti-IL-6 therapy, tocilizumab, that is for early stage cytokine release syndrome or early grade cytokine release syndrome. So I think that part of what we see in terms of toxicity here is a result of early intervention, which is something we've learned from all the other CAR T-cell trials that we have run. That, you know, understanding the potential complications, early intervention can prevent those complications. Neurologic toxicities are generally managed with corticosteroids. Well, I think that these are very important results because unlike chemotherapeutic approaches or small molecule approaches to treatment of follicular lymphoma, this immunotherapeutic approach is agnostic to those features that cause resistance to traditional chemotherapeutic or small molecule-based approaches. For example, patients with mutations in P53 who are generally resistant to chemotherapy, that has no impact on response rates with this approach. Similarly, patients who've had more than 4 lines of therapy have the same response rates as patients who've had 2 lines of therapy. So the amount of pretreatment with the existing agents doesn't appear to affect the response rates. Similarly, patients who are just no longer responding, even to the therapy you're giving them prior to using this approach, even if the disease is not responding to anything, those patients still have a response rate to this that's the same as those whose disease is controlled, but with existing therapy. So I think it's it's powerful therapy. Also, it's been long recognized that the patients who progress after immunochemotherapy with follicular lymphoma, who progress within the first 24 months of therapy, tend to be a group of patients, and it's about 20% or so of all comers of follicular lymphoma that actually need treatment. About 20% of them progress within 24 months, and they tend to be a group of patients that have a poor prognosis. I think the survival at 5 years for that group of patients is about 50%, which for follicular lymphoma is very poor. In any event, this therapy achieves the same response rates in that group of patients. Actually, it wasn't statistically significant, but even maybe even better to some sense. But in any event, achieves equivalent response rates in that group of patients, and again, gratifying and very, very important for that subgroup of patients with follicular lymphoma that are refractory to existing therapies, and even with progression of disease on the currently available treatments. I think it's important to know that CAR T-cell therapy is already approved. They're not the one that I'm talking about, tisagenlecleucel, which is, but there's the axicabtagene ciloleucel product that is already approved for follicular lymphoma, has similarly high response rates, but it's a little more complex to use in terms of toxicities and the necessity for hospitalization. So I think that this product, tisagenlecleucel, that I'm discussing, will be a welcome addition to our treatment tools for these patients.